Introduction to Nursing Concepts. This is Pain Part 2. This is Martha Olson. Our nursing diagnosis related to pain, we have acute and chronic. Remember, the acute pain is your short-term pain. Your chronic is your longer-term, often treated with different types of medication or pain therapy as a result. Your impaired physical mobility, remember, your patients will not want to get up and walk or sit in the chair if they're in a lot of pain, so we want to treat that appropriately to promote that mobility, because we know that that is very important to get them healing and prevent pneumonia and blood clots. Insomnia, oftentimes I will give a pain pill at bedtime with their other HS pills so that they can get comfortable, get to sleep, and get some good quality sleep. And with the spiritual distress, a lot of times they will, make comments like, why did God put me through all this pain, or what have I done to deserve this? Impaired social, I think of the patient that doesn't want visitors because they're trying to control their pain and they just don't feel like they want to be social at that time. In planning, we want to make sure that we promote other things besides just giving pain medications. Plan ahead, get them in a position where they're comfortable, maybe reposition, use lots of pillows, look at the type of mattress that we have, and then look at their lifestyle. What are they used to? As far as health promotion, we want to provide before the pain becomes severe. Anticipating a discharge, we usually give a pain pill before discharge, knowing they're going to be in the car, out of the car, getting in the home, and we don't want their pain to get ahead of them during that time of transition. We pain medicate before a dressing change that has been painful, before physical therapy comes. I, working the night shift, will often give a pain pill about 6:30 in the morning, knowing that physical therapy will be up to work with our total hip and total knee patients about 7. They usually ambulate them in the hall and set them in the chair for breakfast, and so I want that pain medication on board and at its peak when physical therapy comes at 7. As far as implementation, we want to control the environment. We want to do what we can non-pharmacologically to treat them. Close doors and curtains. Try to dim the lights at night. Eliminate any caffeine or alcohol. Try to individualize their pain interventions and collaborate with them on what they think is going to work. Oftentimes it's asking them what's worked in the past. Did 1 or 2 pain pills help? How can I best help you to control this pain? Along with that then is to promote good sleep. Try to give them a snack with milk or L-tryptophan. Give that back rub. Remember, back rubs can be very soothing. Warm the lotion in some warm water or bath water before using it. And then for infants, remember the back to sleep. Babies are always put to sleep on their back to help decrease SIDS deaths. There will be a lot of questions on analgesics on this test because of the analgesics being something that is given, and there's a lot of safety in giving analgesic medications, and pharmacology is a big part of your NCLEX. So as you look at the analgesics in your textbook, you will want to make sure that you're looking at those for this test. When we look at the injectable medications, they work quicker. That's why your patients in the hospital will have an IV, so that we can do an IV push or PCA type medication. Chronic pain, we give something that's going to last longer, have more of a sustained release. We administer analgesics as soon as the pain occurs, because we don't wait till it gets to be a 9 or 10 before we give the medication, because it will take a lot more of the medication to have the same effect. Read up in your Potter and Perry on Demerol. It's no longer the drug of choice. It's hardly ever used anymore because it can cause seizures, itching, and other severe side effects that go along with that. In our PCA pumps, we typically use morphine. With morphine, we have to be careful because it can cause respiratory depression. So we want to make sure that we are checking respirations frequently, especially when they are on a basal level of PCA medication and when they're new to it. So the first 4 hours of a PCA pump, we always check the respirations at least every hour, and the pump every hour, and then after that, then it can go to every 4 hours or as per protocol of the facility. The book talks about people that are opioid native or naive, and we need to look then at the difference of those two. People that are used to opioids are going to tolerate them very differently than somebody that's never had one, and we don't know exactly what to expect. We need to look at patients' liver and renal function because those medications with poor liver or renal function might not be eliminated from the body and have more of a toxic effect for them. The PCA is several links that I have listed in your e-companion, and I would suggest that you look at those. When we look at PCA pumps, there is a lot of potential for error with those, and you want to make sure you're always double checking those with another nurse as you set them up, any questions that you have, and assess your patient. Even though they are self-administering, you'll want to still assess that pain level and see how they're tolerating or doing with that. We have to document any of the narcotics that are wasted with two nurses. So if you only give a half of a tablet, you'll want to make sure that another nurse on the floor watches you waste the other half because it is a controlled substance. The other thing with the analgesics, look at the book. It talks about the Percocet, the Vicodin, the Lortab, the Ultracet are medications that are given with a Tylenol or acetaminophen product, and the reason for that is those two seem to work very well together to decrease the amount of opioid needed. The thing I would caution you in is that Tylenol, you can only have so many milligrams per day, and it's very easy to go over that amount when you are giving pain medications that have the Tylenol with them. And I believe the medication dose now is 4 grams, and they have decreased that. So we watch the Tylenol. Every time you pull one of those Ultracet or Lortabs out, it will ask you how many milligrams of Tylenol or acetaminophen have they had today, so that we aren't going over that level that they're supposed to have. The advantages of the PCA pump, that usually takes less medication with smaller doses. We're able to get a concentration of that medication in them very appropriately, and the overall effect is greater pain relief for them. You can see this patient is able to push that. The PCA pumps are all a little different in some of the facilities, but they work very effectively to help them control the pain. You want to caution the family not to be pushing it. If the patient is not able to push it themselves, then it probably is not appropriate, and the nurse should not be pushing it either. Watch the embedded videos. I would look up your Narcan and know how to administer that medication. It's given for respiratory depression. Potter and Perry states the dose is 0.4 milligrams diluted in 9 milliliters of saline IV push. And if there's no IV available, then you would go with the second fastest route, which would be IM, then sub-Q, and we would never give it by mouth, because if they're having respiratory depression and lethargic, they would potentially aspirate on that. Our epidural analgesia then is put in usually during surgery. The biggest thing that I would tell you is when they have an epidural, we do not give them any other medications at that time for pain. There may be some listed on your MAR, and that is for when that epidural comes out. Your typical epidural will be in for a day or two. Anesthesia may come and give them a boost and then pull that epidural, and then after that you're able to go to some of the PO medications that are listed. If you have pain control issues and your patient has an epidural, you will be calling then your anesthesiologist to get orders on that. If your epidural happens to come out accidentally, you would never want to go ahead and put that back in. You would cover that space with a sterile dressing and give anesthesia a call. Again, we check respirations about every 15 minutes when they have this epidural, and it's considered aseptic technique, and so we want to use very strict surgical asepsis for that site, because an infection going in that site would be right into the spinal column and could become very serious. Our local anesthetics are things we use like when removing moles, when we have to stitch up an area that's been injured, and they usually end in cane. We will want to assess then for allergies to the cane family, because they all tend to have allergies for each other. Any rectal meds would be given then for somebody that's not able to swallow. A rectal med would be appropriate for somebody that has some nausea, and we are trying to avoid the GI system from the stomach up. and also your patients in hospice or near death. A lot of times we will give medications that are rectally for their comfort at that time. Rectal meds would be contraindicated for a patient that's had hemorrhoid surgery, any diarrhea, because obviously that rectal suppository would come right out, and then any of your rectal cancers. Your suppository would not be appropriate at that time. Other things non-pharmacologically we can do, your cutaneous stimulation is your back rubs, you know, using any kind of heat or cold is going to help that as well. Warm baths, maybe they want an ice bag to their back or their neck. You have to have an order, remember, for heat or cold, and so you'll want to clear anything with your physician before doing that. We don't want to put any of those cutaneous things on sensitive skin. So a patient with a burn, with any type of skin rash, inflammation, a fracture, never want to use that. And the other thing to think about is somebody with maybe a potential appendectomy. We would never give them heat because that would cause vasodilation to that appendix and could potentially cause it to burst at that time. So be very careful in using some of the hot and cold therapies that we have. The TENS unit is very helpful. It's transcutaneous electrical nerve stimulation, and those mild electrical currents then pass through the electrodes. I have mostly seen that at the chiropractor. After they do an adjustment, oftentimes they will put a TENS unit on and they will turn it up until the patient says, I can really feel that, and leave it on for a short period of time to kind of stimulate those nerves. Your 3 to 5 minute massage, remember it's appropriate to massage the back, the shoulders, the feet, the hands, but never want to massage the calves of the legs because of the blood clots and potential to dislodge those. And then relaxation, things like guided imagery, where the person kind of focuses on something besides the pain and tries to relax that way. In our evaluation then, we want to chart always if it helped. If they have been given something and we notice that they're sleeping, we would want to chart then, you know, the pain medication was given, they appear to be sleeping, respirations are easy and even, and then ask them in the morning, how do you feel? Do you feel like you've rested and feel, you know, good this morning, and is their pain level at an acceptable level for them? We have some questions here that you guys can work on as practice for the test. When we look at this one, we have a male, and it gives you quite a bit of information that you have to dissect. He's diabetic, so now you're going back to the neuropathy and some of the things that happen to a diabetic. HTN is hypertension, so we know that this patient also has some issues with high blood pressure. He had knee replacement, he drinks coffee, he doesn't nap in the daytime, he drinks a beer at night, and it gives you some medications. And we see the first medication listed there is a Lasix, which we know is a diuretic. Can cause people, if they take it at the wrong time of day or later in the day, to have nocturia. So as we formulate our ideas of why he can't sleep, I can see about 5 things in there that we have just talked about that can potentially cause problems for him. Ativan, the Vicodin. In your book, it talks about those medications as causing problems for sleep disturbance, as well as the fact that he's drinking alcohol and he's potentially got some chronic pain from that knee replacement. Words that we want to know for this unit are listed here. Our special considerations with co-sleeping, that's where infants and children sleep with their parents, and that is a very cultural or personal thing. The problem with that is increased SIDS deaths and potential for a child to be rolled over and smothered by a parent. And then with our older adults, remember, they oftentimes will not report pain in ways that our younger people will. There are misconceptions about pain with the older adult, and we need to think of your patient potentially with Alzheimer's disease and how that might be affected for them. When we look at the answer to this one, we know that Narcan is the answer, that narcotic antagonist. Pain that's not being managed. Our answer is going to be number 3, urinary retention. And are you able to change centimeters to meters? You take out the centi. I hope you've enjoyed this. I'll see you in the next segment. Thanks.